Right, welcome to this video on bronchitis and emphysema. The main focus of the talk will be on chronic bronchitis and emphysema, which is the conditions that we tend to see in hospitals, the so-called chronic obstructive airways diseases. But let's start off with a bit of orientation and look at the anatomy so we're getting the terminology right and we know what part of the respiratory tract we're talking about. So obviously the main airway is the trachea, held open by these 3/4 complete rings of cartilage to keep it open. You probably remember if you're looking at it from the top, they're 3/4 complete rings like that, maybe slightly less than that. And the reason for that is the esophagus is immediately behind it, so it allows boluses of food down. But the rings of cartilage maintain the patency of the airway, which of course is absolutely vital that the airway lumen is maintained to allow air to go in and out of the lungs. Now going down, of course, we divide into the right and left main bronchus. So here we see the right main bronchus, and still with its rings of cartilage to keep it open. And of course, immediately this starts branching into what we call the bronchial tree. But if we follow one hypothetical branch of the bronchus down, of course there'll be many branches coming off, going to all of the areas or the alveoli in the lungs. And these smaller bronchioles here are referred to as a segmental bronchus. The reason it's segmental is it goes to a segment of lung tissue. So a segmental bronchus. And then going down further still, we come to the bronchioles or the small airways. So a bronchus is a large airway, a bronchiole is a small airway. And round about here, I've drawn a line across here because this is really where we go from the macroscopic level. You can actually see this. And below here it's difficult to see because we're getting to a much smaller scale. We're coming on to the microscopic level. And here in the terminal bronchioles, which go into the airways, into the air sacs rather, there's no rings of cartilage anymore. So the terminal bronchioles go down to the actual respiratory bronchioles, and the alveoli branch off from the respiratory bronchioles. So that's the nature of the airways that we're going to be talking about. So we're going to start off our study by looking at acute respiratory conditions, and we're going to start off with acute bronchitis. Now acute bronchitis is just what it says. It's an acute, that means it started recently, inflammation of the bronchial tree. So an acute inflammation of the bronchial tree, acute bronchitis. Now very often these begin as viral infections, and often they just get better if the person's otherwise healthy. But they can go on and you can develop bacterial secondary infections after an acute viral infection. But we're talking about the acute conditions that a person will suffer from and hopefully completely resolve. So let's think about this condition, acute bronchitis. So as we've said, often begins as a viral infection. And typically, initially, there's a cough because of the irritation to the bronchial tree, but it's often unproductive. And it becomes productive later on as the infection, as it were, starts to clear out from the lungs. And quite a lot of mucus can be coughed up later on in the infection. And if there's yellow or green sputum, which there very often is, then this indicates the presence of bacterial infection. Yellow or green sputum indicates bacterial secondary infection. Very often there's an uncomfortable feeling behind the sternum due to coughing and due to the infection itself, and a general tight feeling in the chest. Now remember, the air is going in and out of the bronchial tree through inflamed passages. Therefore there's more mucus and things in those passages. Therefore there tends to be some obstruction. So there can be wheezing as the air gets past the obstructions in the bronchial tree. Of course, because the lungs are involved and the person's ill anyway, there'll be shortness of breath. And of course, whenever anyone has got an acute infection, they shouldn't exercise anyway. There may be mild fever because of the infecting viruses and bacteria. And typically this is a self-limiting condition. In otherwise healthy adults, the condition resolves in about a week normally. And bronchitis is fairly common in childhood, after any childhood infection such as measles or whooping cough or typhoid. And of course, a bit of bronchitis for most children, they will recover from it fairly quickly. But if you go into conditions where there's a lot of poverty or nutrition is poor or living conditions are poor, then a lot of the children do have a degree of bronchial infection for much of the time. So in healthy children, the conditions tend to resolve quickly, but other intercurrent infections or living conditions in children that are in any way immunocompromised because of, for example, malnutrition, then bronchitis can become quite a severe problem. And of course, if it's bad, it can go on and infect the lung tissue itself, which we would refer to as pneumonia. So we've looked at acute bronchitis. Let's just think about children now. And it's a sobering thought to realise that perhaps chest infections are the most common single cause of death in children in the world. Now, this depends on the age group of children you're looking at. In very young children, it would be diarrhoea that's the most common cause. But simple chest infections kill an awful lot of children. So this means we need to be on the lookout for them, prevent them if possible, of course, and treat them fairly seriously and give antibiotics when it's appropriate. So what are the factors involved in predisposing children to bronchitis and these chest infections, these potential life-threatening conditions? Nutrition. If the child is malnourished, then they're going to be immunocompromised. To have good immunity, you need to be well nourished. Other concurrent infections are going to predispose to bronchitis. It seems that the body is only good at fighting one infection at a time. If there's other infections in other places, then chest infections become more likely. In overcrowded conditions, the children spend a lot of time breathing in other people's pathogens, breathing in bacteria that have been breathed out by other people, transmitted by droplet infections. And in the same way, if the living conditions are poor, especially if it's damp, and the child's inhaling water vapour into the lungs a lot of the time, again, bacteria can adhere to the water vapour and cause infections. So bronchitis in children, just like in adults, it often starts with a viral infection, and the RSV virus, the respiratory syncytial virus, is the most common in young children. But bronchitis in children over the age of 6, if it's clinical, is more likely to be of the bacterial type. Therefore, antibiotics should be considered. Just as with the adults, the cough can be unproductive initially and becomes productive after 2 or 3 days. And if the child's otherwise healthy, they will recover again in 5 to 10 days, in a week or so, providing that their nutrition is adequate, there's no concurrent infections, and it's not exacerbated by overcrowding and other poor living conditions. So let's think about treatment of bronchitis in children, or indeed any acute bronchitis. Well, antibiotics work very well against bacterial infection. Typically, amoxicillin 250 milligrams 3 times a day will be an adult dose. Amoxicillin works quite well against most types of bacteria that infect the bronchial tree. There's many others that can be used. Aspirin and paracetamol might make the person feel better if there's a pyrexial component. Analgesics, if the chest is bothering them, if there's pain, can be considered. Humidity can sometimes help because the water vapour and the very fine water vapour in humid air can keep the secretions mobile and therefore allow them to be expectorated. And of course, all sick people should rest. And in children, bronchiolitis, infection of the very small airways, can occur. This is quite a serious condition. And sometimes hand-to-nose transmission of a virus can give fairly big outbreaks of this. And children